My guest today is Professor Terrie Moffitt, who's University Professor of Psychology at Duke University and Professor of Social Development at King's College London. Her expertise is in the areas of longitudinal methods, developmental theory, clinical mental health research, neuropsychology, and genomics in behavioral science. She's uncovering the consequences of a lifetime of mental and behavioral disorders on processes of aging. Welcome, Terrie.
Hi, yes, that's right.
Yeah, thanks for doing this. So I have a couple of your papers, and we'll start with one of your recent papers, Disparities in the Pace of Biological Aging Among Midlife Adults of the Same Chronological Age Have Implications for Future Frailty and Policy. So you say here some humans age faster than others. Variation in biological aging can be measured in midlife, but the implications of these variations are poorly understood. We tested associations between midlife biological aging and indicators of future frailty risk in the Dunedin cohort of 1,037 infants born in the same year and followed to age 45. So we will talk about that study from New Zealand or cohort from New Zealand. But I want to abstract this problem a little bit, Terrie, before we get into the details of this. So would you consider aging to be a disease?
Oh, goodness. No, in fact, I was taught when I was in graduate school that, it was very wrong-headed to think about aging as a disease.
Hmm.
And now that I'm doing research in the field of aging, these many years later, it seems to me to be what my team is really trying to do is to separate the measurement of aging from just being sick. So when we study research participants, one reason we follow them through time is we're looking to find out if their organ systems are all declining or deteriorating together at the same rate in a coordinated way over decades, and try to separate that out from just periods of having disease or periods of being unwell. So that's kind of what our research and our paper is all about, really.
So I'm thinking with the biological systems, it seems like, so let me ask you this. Do single cell organisms age?
I don't know a lot about single cell organisms
Okay.
because I'm a clinical psychologist, but yes, of course they do. Yes,
Yeah, so,
everything that's alive ages. Yes, I think that's
okay,
fair.
so I was thinking, I mean, I don't know anything about this, obviously. So is sort of, aging came to us through complexity. So single cell organisms become multicellular organisms and so on and so forth. And then aging, we can see aging very specifically. What was it sort of an error in evolution? I mean, it doesn't seem like aging has any beneficial effect on the biological system, or am I wrong about that?
Well, there have been theories in the past, mainly coming from, say, anthropology,
Hmm.
which, are that people who grow old then can contribute by looking after their grandchildren, offspring, and that creates the greater likelihood of survival. And so survival of the fittest requires grandmothers and grandfathers, so that genes are passed on for people who live longer in that way. On the other hand, it's what we know is that really when genes are passed on, it's when people are of reproductive age. And
Hmm.
so once people have passed reproductive age, there's no further advantage to continuing to get older. So there is a social advantage and a personal advantage, but not a biological advantage, really. The thing is that one's, genetic predisposition to become, say, a centenarian or live to be past 100 does then overlap with your vulnerability to all manner of diseases,
Hmm.
including mental health problems. So they're almost what's the word I'm looking for? It's hard to disentangle them. Yeah,
Yeah.
they go hand in hand, genetically speaking.
So If reproduction was sort of a single factor objective function, then the biological system could have continued reproducing forever. I mean, why do we have this age-related constraint on it?
Hmm. You know, there are really theories about this, and I think they are better answered by the
Okay.
people who do. There's a whole group of gerontologists. A lot of them are actually their scientific roots are in their education in Russia,
Yeah.
and they do exquisite mathematical models of the to answer the kinds of questions that you're answering.
Hmm.
I'm not part of that group, but I think their work is fascinating.
Yeah, so let's talk about the thing that you have been doing. It's just really fascinating. Done it in pace, done it in study. I understand that this is a town in New Zealand
Mm,
where you
right.
had about 1,000 people in the early 1970s. And then you sort of followed them through, making measurements for many, many times over their last 50 or so years. And so
Right.
what do you find? What do you find from all these measurements?
Well, first, let me just say tell your readers that Dunedin is a beautiful city, and if they ever wanted to go and visit the University of Otago, I highly recommend it.
So
Um,
where exactly is it?
Dunedin is the furthest south medical school. It's on the east coast of New Zealand, and so there's nothing between Dunedin and Antarctica except open ocean.
Oh, wow. Okay. Yeah. I know only two cities in New Zealand. I've never been there. They're
Uh-huh.
called Christchurch and Auckland. That's because they're
Right.
two cricket fields.
That's right.
It's-
That's right. Well, people in
yes.
New Zealand are crazy about cricket, in addition to rugby and lots of other sports. Uh, but Dunedin is where the University of Otago is. It's where the obstetrics and gynecology department back in 1972 started collecting data on a series of every baby born
Hmm.
in that city at that time, and no baby was excluded. And that's turned out to be very important because usually when we're drawing research samples today, we're excluding people who have, um, you know, some kind of mental health condition or some kind of medical condition. But this cohort is really representative of the population of New Zealand's South Island. Now, with one thing your audience may know is that over time in longitudinal cohort studies, lots of people drop out, and those people tend to be the people with the health problems and the mental health problems. In the Dunedin study, we still have a 94% participation rate 50
That's an
years
amazing
later.
thing. That's an amazing
So
thing. Yeah.
it's a terrific. That's one thing that's very unusual about this particular cohort, and it's why I love studying it. It represents the full gamut of variation from very, very, very unwell people who are aging really fast to super healthy people who are aging really slow.
Yeah. So the 6% lost. Is it due to mortality or is it really dropout?
There's some mortality. There's a few people that we've lost track of. And then there's some people who don't attend at any particular session, a data collection session, but they go and come and go. So it's never the same people who have cumulatively dropped out. And we have people now who are taking part at age 52 this year who didn't take part when they were
Oh, wow.
45,
Okay.
So people do get excited about the study and they come back in as soon as they can.
Okay. And so talk a little bit about how this happened. Um, so you talked about, is it University of
Otago.
Otago?
Mhm.
Um, so were you involved then, or you got involved later?
Oh, I got involved in 1985 as a postdoctoral fellow. This
1985.
this
Okay.
sounds crazy, but the Needham study members were 13 years old then, and I finished my training at UCLA in neuropsychology, and I was very interested to test a whole cohort of 1,000 children before they became teenagers in order to measure their verbal skills, their executive functioning, their speed of processing information, and to look and see if those kinds of neuropsychological characteristics would help to determine which ones of them got involved in dangerous and risky behaviors while they were adolescents and young adults. So we looked at that time at risky sex, we looked at juvenile delinquency, we looked at drug and alcohol abuse, that kind of thing. Now, so why am I sitting here today talking to you about biological aging? That's because for a longitudinal researcher, your cohort keeps growing and you have to change and remake yourself and your interest in order to study the things that are important in their lives at the time. So as you follow them forward, let's say, we may have studied potty training when they were 3-year-olds, and now we're studying menopause and retirement savings. So it's a byproduct of this particular long-term longitudinal method that keeps the scientist on our toes.
Yeah, but so it's a fairly homogeneous cohort, I would think. They're all exposed to the same environmental factors, perhaps different educational factors. I don't know in that area. They are all eating reasonably the same food. So many of the controllable factors are constant. And hence, what we find in that cohort is actually more usable in some ways, right?
That's an excellent point. One of the things that's most important about them for studying aging is that they were all born the same year. So one of the aspects of studies that are in the Northern Hemisphere of aging tend to be, they study people aged 18 to 90, say, for example. And the cohort then, it's hard to tease apart if they're biologically different, the young people versus the older people in a sample, because they have lived through different eras of medical care. So the older people are older, yes, indeed they are, and you can study their biology and compare them to the younger ones, but they also grew up without antibiotics, and they grew up without ibuprofen. They grew up without vaccines. So their medical care, they grew up without birth control. Their medical care has been a really different history, and that's left an epigenetic legacy on their genome, which is not aging, doesn't have anything to do with aging. So one of the cool things about the Dunedin study is they were all born in the same year, 1972, 73. Now, I just want to address quickly your notion that they lead a pretty uniform life. In fact, they run the full gamut from very, very poor people growing up in deep social disadvantage and economic disadvantage to people who are today very wealthy, or in their childhood also were very wealthy. So there's quite a lot of variation within in terms of their diet, their physical activity, their access to healthcare was held constant because of the national health system of New Zealand. But other things in terms of lifestyle varied quite a lot. Then I should also add that because New Zealand experienced a staggering recession, one of the worst that the world has ever known, just at the age when our study members graduated from, left high school, left secondary school. Only 1/3 of them still live in their hometown on the South Island of New Zealand. The rest ended up moving to the big cities of the North Island of New Zealand, Wellington and Auckland, or moving to Australia. So they live in Sydney or Perth or elsewhere in Australia. And many immigrated to Europe and the United States and Canada. So by today, their lifestyles are really different and their locations are really different. This would make them a great study to look at, say, for example, the gut microbiome. We haven't started doing that yet, but I hope we'll entice a scientist who's interested.
Yeah, the gut microbiome would be very, very interesting. So there's some sort of social trauma that they experience, but you're still retaining 94% of the original cohort. So these people haven't moved.
No, when it's time to collect data, they fly back to Dunedin. So we
Oh
cover
wow.
the cost of that.
Okay. Yeah.
It's
So
part of the
that.
research budget. And one of the secrets to why the participation rate is high is because the participants do get a plane ticket home and they
Hmm.
can then visit their grandparents or their parents. So that's a big draw that most studies in North America are not able to offer that kind of thing to get their participants to come back and take part. But also, I must say that they're all fiercely devoted and loyal to the study and very proud of being in it. I mean, one of the things that they've said, we just last week there was a documentary television program on Television New Zealand about the Dunedin study, and one of the study members reported to the director, um, I feel anonymously famous.
Hmm.
So we have protected their confidentiality all these years. No one knows who is actually in the study,
Hmm.
but they feel that they represent their small country overseas, bringing medical knowledge to the world, almost like an Olympic team. They feel anonymous and yet famous.
And get
So I think
famous. Yeah.
that's the main reason why people still take part after 50 years.
Yeah. I mean, we haven't done anything like this. So this is a unique thing. You mentioned microbiota. So I'm wondering, so do you have sort of segmented thing that you can look at? People who went to England or the US or some other place that come back and do the measurements. Do we see some significant effect on the microbiota and related aging issues?
We haven't collected data on the microbiome. We do have the dental, I should explain about the study that there's a mental health team
Yeah.
and social development team. There's a team that's of respiratory medicine doctors that studies them, a team of oral epidemiology dentists who study them, um, a team working on oxidative stress who study them. So there are many different research teams who collect data from this cohort. And the cohort come in at 8:30 in the morning. They stay the full day,
Hmm.
and they're seen by lots of different medical research teams throughout the day. With professional clinical assessments. Then at night, they leave and go sleep, and they come back the next morning and they are seen by the neuroscience team, and they have a brain MRI and they have a photograph, retinal photographs taken.
Hmm.
So for the ophthalmology team. So they're being studied by a lot of different a lot of different people. Does that help understand what's happening?
Yeah. So you're looking at them from different angles, and I'm just
Mhm.
thinking about. Um, so suppose we found environment. I'm just making this up, Terry. I have
Okay.
no clue. Suppose we find environment and food
Mhm.
are very important determinants of aging. I'm just making this up. I have absolutely no clue. I grew up in South India. My dad is just turned 90. My mom is 80. And it's a very poor country, as you know, about $2,000 per capita GDP. And there has been some speculation about diseases and aging related to food. I had somebody from UCLA recently talking about turmeric and spices substantially changing their sort of the health profile. So
Oh,
how do you
fascinating.
control for people coming back on that flight back to Dunedin, and they have a different physiology in some ways, right?
They may do in certain things. We do collect data on where they live in the world and how long their plane flight would be, how much jet lag they had, how many
Hmm.
hours they were off. But we try to get them to come and then spend some time visiting to acclimatize before they come in to to the data collection day, because of course there are certain things that they might go through that, as you say, could be affected by that. So one way to deal with it is to collect data and use that as covariate controls in all the statistical analyses. So far, we find that it hasn't mattered, but it could be that if you were studying something having to do with diet, it could matter. But it hasn't mattered. Say, for example, the brain, the functional MRI bulb signals, very sensitive to the amount of fluid in the body, which would, and in the brain, which would be affected by a very long plane flight. So we have looked at that and we don't find any effect. So some of the effects of living overseas that you would think in theory should be important turn out not to be as something to worry about.
It's really interesting. So it's sort of pushing toward the hardware, not the software, so to speak. And so what do you find? So what are the factors that has high correlation to aging in your study?
Right. So here's one of the, maybe I should just explain a little bit about the way the research on aging has worked in the Dunedin study. What we have mainly done there is we have every year, as the study members have been growing up, we have collected biomarkers from all of their bodily systems. And so these are things like ordinary blood chemistry biomarkers that you would get, that your GP would take when you go for an annual physical. Things like cholesterol, things like your kidney function, blood pressure, waist-hip ratio, but also contribution of biomarkers from the dental team, such as gum disease biomarkers. Respiratory medicine team contributes lung function biomarkers. So we track all of the different organ systems as the people have been growing up. We see them about every 5 or 6 years. So that gives us a long-term longitudinal record of how their entire body has been functioning since they were in their 20s, and now they're in their 50s. We take all those data and we model them so that we come up with an indicator, a single score for each individual of how fast their organs have been declining together. Now, as I said before, if they have 1 or 2 biomarkers that has spiked at one point in time, like let's say their lung function is bad when they were 32, that could be because they just had a respiratory infection at the time. We're not interested in that. What we're interested in is when all of the organ systems are changing and declining in their function slowly and gradually over many years together. That's our operational definition of aging, and that's why it's different from having a disease. Now, once we got that score, then we could use that score for each individual to look at what other things in their lives related to it. And I think that's what you're asking me now. It's like, what kinds of things are predicting their aging? So, I could just ask your audience to guess, and every hand would go up, and people would say, cigarette smoking. And for that, you win the prize, yes. But you don't win an NIH grant for that. So what else? What else affects their aging? We know that from the Dunedin study that people who grow up with very severe childhood adversity and disadvantage and threat from abuse tend to be aging faster. We have looked at childhood diseases to see if any of those predict how fast people are aging. And one of the things we know is that people with asthma do not age faster in this study. So that's good news. So we've been systematically going through all of the health and social aspects that we have. People who are living as an adult in a relationship with domestic violence are aging faster. So these things point to stress as one thing. And that's really important, in addition to, say, the cigarette smoking and chemical effects. Now, what we can do in the Dunedin study, because it's 1,000 people, and as you mentioned before, we want to know more things than what you can ask of a single cohort that's grown up in a single environment. We've exported this score now to so that other research teams can use it. So how do we do that? What we do is we look at the epigenome, which is the marks on top of our DNA. These marks is kind of a loose term, but it's something that turns genes on and off and influences their operation.
Yeah.
Those change and accumulate as people age. And so we have been able to detect, using the DNA of the Dunedin study members, which of the epigenetic marks are more related to people who are aging the fastest in the cohort, some of those who are aging 2 years biologically for every 1 year chronologically, and then how the epigenome is different for people who are aging very slowly. Let's say they're aging 10 or 11 months biologically for every 1 year chronologically of age. We obtain that epigenome score, and that epigenome score can be calculated for anybody, for you, me, any of your listeners.
Just with a blood test?
Yes, just a blood test.
Yeah.
And it's possible to do that by a finger prick, getting a drop of blood on a filter paper, mailing it into the lab, and obtaining your pace of aging score. So once we were able to do that, that meant that then other research teams who perhaps had not been following their participants, longitudinally for decades, if they even just had a new cohort like the UK Biobank, for example, some of those could implement this score in their samples. So at this point now, there are more than 60 different research teams at labs all around the world who are using the Dunedin PACE score. We call it Pace of Aging Calculated in the Epigenome, Dunedin PACE, and they're using it in their research. And so what we have is a lot of findings about what influences the pace of aging that are not from me and not from my team, but they're from other teams. So I just wanted you to understand that, because it would sound incredible if I named lots of things that influence the pace of aging and tried to pretend that I came up with them myself. If you'd like me to talk about some of those, I can do.
Yeah, it's really interesting. So I don't know if I'm thinking about this correctly. So when I go to my physician, my general practitioner, do a blood test, we look at triglycerides, we look at cholesterol, we look at A1C. If I understand you correctly, we could have a supra measurement on top of all of these things. So rather than measuring all of the stuff that we've been measuring to get people healthy, we could actually measure something all of these things are driving toward, which would be some sort of an epigenome change factor. I don't know what it is, right? And if we can create a blood test for that, that basically tells you sort of the state of health for that human being, rather than sort of disaggregating. And it's a bit like engineering. We look at all sorts of numbers, but then at the end of the day, you're asking, is the building standing up without falling? And so I think we have gone into too much detail.
It's actually quite easy to create a summary composite, of all of your biomarkers that are taken, at your annual physical. That's easy peasy, but that doesn't tell you how fast you've been changing over time. And let me just give you a thought experiment. What if a person was born, let's say one of the studies that's been done is the people in the Netherlands who were fetuses during the Dutch hunger winter. When the Nazis were occupying the Netherlands and there was nothing to eat but tulip bulbs. Those infants who were subsequently born have now been followed into midlife, and they have a faster pace of aging. So one of the things that we know is that they are aging fast now. It's because the pace of aging is a longitudinal measure that tracks biomarkers over time. It's not that they were born old, it's that we know that they have been more recently, they have accelerated in their aging as they enter midlife and late life. So it's that It's that pace part, it's that longitudinal part that is the special sauce in the
Yeah.
pace of aging, if that helps to clarify
Yeah.
it. Yeah.
No, that's an important thing. So we have had some economists and some medical experts on the show. Um, so initial conditions matter a lot. So I want to sort of get your perspective on policy here.
Mhm.
Um, as you know, in the US, we have a huge healthcare issue, quote unquote. Healthcare provision has been highly varied. Um, yeah. And with the new administration, yeah, it could be even more disastrous than we have been. So what you are, if I understand this correctly, Terry, that the first few years, your initial conditions matter a lot as to how healthy you're going to be in the future. And so if society has any investment, any money left to make, it's in the health of infants, right?
Well, one of the things that we have looked at in the Dunedin study is whether people, if they rise in the social class structure, that is, if they get lots more education than their parents had, and if they, over their lives, end up making in a much higher income group than where they began in their family, does this, does their health show a concomitant improvement?
Mm,
Along with their social class, and it doesn't.
it doesn't.
So that fits with what you're saying, that some aspects of early life disadvantage stick with you. There appears to be some kind of critical period early in
Mm,
life for developmental biology where things like the strength of your heart muscle
mm,
or the speed at which your neurons fire can be, to a certain extent set early or harmed early in
mm.
life, and they don't fully recover, at least by midlife, as long as we follow the Dunedin study members. So
Wow. Yeah.
yes, that's true. Now, I want to mention something about policy. I've been reading a lot in the newspaper about the new administration, the new government administration coming in the United States, and the big $64 million question of whether the new administration will change the age of eligibility for Social Security and
Mm,
make it older. You might think that it would be good to make it older. That would, help save money. If people had to wait until they were in their 70s to get Social Security instead of getting it in their 60s. But what we find in the Dunedin study is a huge amount of individual differences, that is, differences in the population in how fast people are aging biologically.
yeah.
So our Social Security number of eligibility depends upon our chronological age. But
Mm.
that's really kind of, administratively, that's easy because you can just, when people were born, and so you decide when they're going to be eligible for Social Security supports for retirement. But there are many people who are, let's say, eligible for Social Security at age 62. Their
Mm,
biological age may be age 70. So
yeah.
they have difficulty making it. They can't keep working. Their bodies are falling apart
They'll be dead
prematurely.
before
Right.
before they
Yes.
get
So we
Social
need to take
Security. Yeah.
account of that when we set. I don't suggest that the government give everyone a pace of aging, an aging biology test. I think that's a little bit implausible, although I wish that would happen. But what we do need to do is, if the age of retirement is of eligibility for Social Security is raised, we need
Yeah.
some mechanism for allowing for variation in biological disability levels around chronological age. So there will be some people who, like me, I'm turning 70 next year. My pace of aging is quite slow, although a little bit overweight, but otherwise quite fit. And I could keep working, another 10 years. I don't really need Social Security. But my brother, who has been, a more blue collar worker most of his life, did not make it for retirement until
Hmm.
age 62. He had to retire early because he, hips, knees, heart,
Hmm.
other aspects of his body were falling apart. So that's just within one family, you can see this very wide difference in how people are aging, and it influences policy.
Yeah, yeah. I'm yeah, this is a very, very complex issue, obviously.
Sure is.
So there's an incentive. So suppose just as a thought experiment, suppose we say Social Security happens when your biological age hits 65, then that's going to put an incentive into the system to possibly do things differently, right? So I don't know if that will actually get to an optimum policy, but
So
it's
do you mean that people
yeah.
would sort of reduce their own health behaviors in order to get retirement benefits early?
I don't know.
Anything
Suppose
is
I put a tax
possible.
on soda or hamburgers.
Yeah, right.
I feel
I've been
like
thinking
yeah,
about, taking up smoking again because on my birthday next year, because, I can work the numbers. I can see how long it takes from smoking cigarettes to cancer risk increasing, and I'll be dead of something else by then. So
yes,
if I was really enthusiastic about smoking like I used to be as a teenager, I could start again next year.
yes,
So yeah, I see where you're going with that. I kind of think that people in general don't like being dependent and
yes.
like to be independent. So that's a kind of a human drive that would probably keeps most people working as long as they're able.
Yeah, so I mean, I don't think this is a policy that's implementable, but if you take the 19 factors that you have in your study and I come with some sort of differential tax on those factors, with the goal of, sort of optimizing societal health and societal deployment of resources. Um, I don't know how to implement this, but that would be an interesting thing, right? So if you say these behaviors, like you say, smoking or high A1C, you say, I just drink soda and hamburgers, I eat hamburgers. We have a president who does that all the time. He seems pretty, he seems pretty healthy, actually.
He does.
Um, and so suppose we impose differential taxes on these factors. Do you think we can move to a more optimum position?
Well, we already kind of do that with our sin taxes. So we tax tobacco heavily and we
Yeah.
tax alcohol heavily. And I don't know that we tax hamburgers heavily, but it's an interesting. I love thinking like an economist. I'm not a trained economist, but what my economist friends have taught me is that we have to be wary of their law of unintended
Yeah, yeah,
consequences.
right.
So, yeah, I think, the psychological drive that people have to be capable and competent and in control of their lives, I
Hmm.
think that pushes them to try to be as healthy as they can and to try to work as long as they can. Maybe I'm naive in having this, fundamentally positive view of what people in midlife and late life want. Um, uh, but but yes, it's that is a bona fide way to change people's behavior is using the tax system. It works.
I hate taxes. I was just suggesting it, but uh, so I'm going to touch on this mental health aspects, which is sort of counterintuitive in many ways. So you mentioned it already. So early childhood um, bad conditions from a mental health perspective seem to accelerate aging later. And what do we know about? I mean, it's a very, very complex system, but do we know the mechanism by which this happens?
Well, no, but there are lots of great ideas. So one of the things that the research shows absolutely clearly is that people who have mental disorders, and the more mental disorders they have for the longer number of years, those things all are strong predictors of their pace of aging when they reach midlife. So you may no longer have a mental disorder, but if you have it in your past, it still predicts a faster pace of biological aging.
Mm.
We know that the more severe disorders, people with disorders such as schizophrenia, die 10 years younger than the rest of
Mm.
the population. And we have looked at whether it's childhood mental disorders experienced in early life. The important thing is that the peak age of mental disorders is in our 20s. If people are going to develop depression, bipolar disorder, schizophrenia, those kinds of mental disorders tend to come on in your teens and 20s. And
Mm.
the vast majority of people who are ever going to have a mental disorder in their life will have it in their teens or in their 20s. So that
Mm.
means that the mental disorder comes early. And then the age-related diseases such as heart disease, diabetes, Alzheimer's come late. So there's a natural kind of a temporal order there, if you
Mm.
will. And we can look at those early mental disorders and how they relate to later pace of aging as measured with our biomarkers and to onset of disease diagnoses and to the date of death. So all of those data, there are
Mm.
hundreds and hundreds of studies, and they're quite clear about that. So then why is mental disorder so bad for your longevity and your health span, your capacity to have healthy, vibrant older years? There are many different theories. One theory is simply that the brain is the canary in the coal mine, and
Mm.
it goes first and starts showing malfunctions, and that you see in
Mm.
mental disorders, and then later the rest of the body
Yeah.
starts to go. But this was always a person who had a tendency towards ill health.
Mm.
So that's one theory. There's just a simple theory about genetic similarity in the genetic substrates for mental health problems and physical health problems. The genome-wide association studies are now tending to show that the genes for mental disorders are not so much different from the genes for medical and physical disorders. So that's very interesting.
Mm.
Um, and then there's the simple fact, which is one that would lend itself more maybe to interventions, and that is health behaviors. So we know
Yeah.
that people with mental disorders don't take very good care of themselves. People with depression and schizophrenia tend to be socially isolated, so they don't have a good support network.
Mm.
They don't get access medical care, even if it's freely available to them. The studies in Scandinavia show. Um, they tend to smoke. They tend
Mm.
to, not eat healthy food. They tend to not engage in physical exercise. So all of those kinds of things, the health behaviors and lifestyle kinds
Yeah.
of questions, I think are probably, to my mind, one of the front runners.
Yeah.
Sleep is also really important. One of the key factors in depression, anxiety, and schizophrenia is disrupted sleep. And
Mm.
we know now that disrupted sleep is a good predictor of a fast pace of aging in midlife and of diseases in later life. And there has been at least one study that has done sleep interventions and improved people's sleep and showed that
Mm.
their pace of aging slowed down.
Mm.
So that's one study that I know of. It's been presented at a conference. I'm pretty excited about it.
So is it mental disorders or is it mental stress?
Well, mental disorders tend to be what's measured.
Okay.
So we have, studies around the world, and now we're looking more and more at um, getting away from surveying people with self-report interviews and asking about their symptoms of mental disorder, although that's an excellent way to assess mental disorder. And of course, it's what psychiatrists do, and we
Mm.
do it in our studies. But an alternate way is to look at um, national medical
Yeah.
registers. So there you can see who has seen their GP and been diagnosed with a mental disorder at any time in the past 30 years, and then look at their later diagnoses. What are they having in terms of Alzheimer's disease, heart
Mm.
attacks, diabetes, and those kinds of illnesses. So you can do that within a medical electronic medical records, and there you can use samples, along the size of millions and millions of people, because you can have, and we have done papers this year that we've published on the entire country of Norway, or the entire country of Denmark, or the entire country of New Zealand. So when you say, is it the stress? Stress tends to not be noted in an electronic medical record chart, right?
Yeah.
So I point to mental disorders because I think that's where the really strong evidence is in those nationwide studies. But even the smaller, more clinical studies that ask people about their subjective feelings of stress are also, showing the same thing.
So if you go back to your Dunedin study, are there any factors that captured, personality, or, people who are smiling more or easier to get along or anything like that? I mean, there's sort of the qualitative factors that you have captured in that data.
Yeah, we've started studying the children's temperament when they were 3-year-olds and 5-year-olds, and then when they were 18 and in their 20s, we gave them extensive personality assessments, and we're doing that again this year at age 52. And one of the important things about assessing a person's personality is to use the psychological measurement instruments that are available to collect their self-report, so they answer lots of items about that give you clues to their personality, what kinds of values they have, what they prefer, what kinds of settings they're comfortable in. But then we also collect data from their loved ones, from their partners, their friends. So we collect what are called informant reports, and those are really, really important because they tell you what kinds of personality traits other people see in the research participant. And then we also have our staff, the clinical staff, say the cardio nurses, people like that, who are collecting data from the study participants in the clinic and in the lab, and they rate the study member's personality after they leave the assessment day. So that's called personality on first impression.
Yeah.
And you might think, oh, how could a nurse seeing you just for an hour rate your personality? Or, but in fact, that's what happens when you go on a job interview. You get 30 minutes to impress your personality on your future boss. So it's important. It's an important kind of information about personality. So we look at all of those. Turns out that what's most important for the pace of aging and for late life health is your two things, your conscientiousness and your negative emotionality. So shall I say more about those?
Yes, please.
Okay, so I learned this idea about conscientiousness from sitting next to an executive, a CEO of a big Midwestern insurance company, medical insurance company, on an airplane. And he told me that what they look at when they're trying to do actuarial prediction of how soon a person's health will break down and how much health insurance they will need is they look at their financial records. Okay, they look at their credit rating. And I said, oh, really? Why is that? And he said, because people who are not conscientious about their money are not conscientious about their health. So we took this back to the Dunedin study and we looked at this. We got all of our personality ratings about conscientiousness, and we also got their credit ratings. We collected the study members' credit ratings with their permission, and then we started to look at their cardiovascular health in midlife and their pace of aging. And it turns out that really, he was right. People who are not careful, planful, responsible in life in general tend to have worse health outcomes in the long run. So that conscientiousness turns out to be very, very important. And if you think about it, it makes good sense.
Yeah.
The negative emotionality trait is the tendency to experience fear, hostility, alienation from others, to feel that other people, if you're in an ambiguous social situation, to expect the worst from other people, to think that other people are out to get you.
Conspiracy theories.
That's right. And that, as it turns out in the Dunedin study, was a strong predictor of who did not want the COVID vaccine when it came to New
Hmm.
Zealand. So there's a good health behavior. Negative emotionality is associated with poor health behaviors, and poor health behaviors are associated with worse health.
Yeah, that's really interesting. I mean, I'm just fretting about with AI taking off. Very soon, you mentioned
Mhm.
the insurance company CEO. Very soon, they will determine what their payout is going to be for this enrollee for the next 50 years. And if it's above a threshold, they can just walk away from it. Um, and so that's huge implication. I mean, the US healthcare system, as you know, is broken in many ways. The intermediary who doesn't add any value, the insurance company, makes a lot of decisions between the provider and the patient. They add no value. They have a lot of accountants, a lot of finance guys running around, and the CEO probably has an army of finance guys in their headquarters doing all the statistical analysis, and they typically make bad decisions, I would argue, even with all that data. So we have a huge problem, I think, in healthcare. And this goes back to the initial conditions issue that we talked about, which is if there was an insurance company in New York that found using AI that African Americans require less care. And what's the data that went into the algorithm? All the historical data. African Americans received less care. That's sufficiently robust to predict an African American walking into the hospital requires quote unquote less care. And so we are on a very, very slippery slope here with AI taking off and people trying to maximize profits in the healthcare system, I would argue.
Yeah, this is where you're a better economist than me, Gill. I'm not sure the American healthcare system is completely broken. I mean, I've lived many years in Britain under the national health
Yes.
system and years in New Zealand under the national health system. And I tend to feel when I'm in the United States that I'm getting better health care, and
Hmm.
I'm certainly getting it faster. There's no doubt that it's more expensive. And there's no doubt that we don't live as long in the United States. We don't live as long as people in Britain. So it's one of these things that, like you've said before, wow, is this complex? And there's so many things feeding into it.
Yeah.
How the AI is going to play out and whether it's going to be used for good or for ill, I'm not sure we can blame that on the AI
Hmm.
because it's there anything can be misused, right?
Yeah.
So it's you're right. It's going to be the actors that are responsible for how it's used, and then whether the profit motive tends to improve healthcare or damage healthcare for some people. I think, also that's that market forces often improve
Hmm.
uh, products. So you're a better economist than me. But, I have a lot of questions too. And I think it's something that, it's fascinating to read about. And we have to stay informed. We have to stay on top of it.
You have to keep going. So I want to, so in conclusion, is the Dunedin study sunset or is it going to go on for a while?
Oh, it's going to go on as long as we can keep raising money for it, I think. No, we have grants now from the UK Medical Research Council, from the American National Institute on Aging, and from in New Zealand, the Health Research Council and the Ministry of Business and Innovation. So we have funders who are holding hands and sharing with each other to support us. And that's very exciting right now. And I think that we will continue as long as we keep coming up with really good scientific ideas, good scientific questions that the funders want to support and the peer reviewers think are important. And as long as the study members will keep participating as well. So we don't have any plans to shut it down in the next few decades.
Please don't. I mean, this is a unique data set, and with 94% retention rate after 45 years, it is really, really unique. And so I hope you continue for another 30 years so that we can get more data and understand. I mean, aging ultimately kills most people
There you
unless you
go.
get into a car without a seatbelt or something like that. Um, and so understanding aging is very, very fundamental to human health. And if we have any better insights into it, I think it is hugely beneficial for humanity. Yeah.
Thank you for that. I find it very meaningful work. I really do. My hope is that our measure of the pace of aging will find its way into applied medical care. There's a couple of
Hmm.
ways it could do that. Just quickly, one is that at the moment there are certain surgical procedures for older adults. You're not allowed to have them if you're past a certain chronological age because the surgeons presume that you won't
Hmm.
be able to recover after the surgery. However, once again, there are people with the same chronological age who are biologically actually much younger than their chronological age. So
Yeah.
those people should be tested with the pace of aging measure to see if they could be eligible for surgeries if they want them and if they make a commitment to the physical therapy and the recovery. So that could be a good medical
Hmm.
application. And another one could be when the new drugs become available for Alzheimer's dementia, especially the prevention drugs that will prevent cognitive decline, they're going to be very expensive.
Yeah.
And there needs to be a way to test people to find out who would benefit most and who needs them most. So this
Hmm.
kind of a measure could fit into that kind of a workup and assessment about who would benefit from the more costly types of healthcare. So I'm kind of excited about
Yeah.
that working out, that's our long range goal.
No, no, it's a very practical thing. And so anecdotally, my mom is 80 years old. She probably would benefit from a knee surgery, but she's type 2 diabetic. And so she's outside the window, so to
Right.
speak. And so, yeah, it's interesting. I mean, um, you have to, I mean, if you can have robustly conclude biological age, that might have some benefits for care in many, many settings, I would imagine, many, many, medical settings, I would imagine. Yeah.
Yeah, I hope so. I mean, I think that, doctors, let's say in the case of your mother, they could very carefully consider the function of all of her different organ groups besides just the diabetes but they don't have time. So they need something simple that could give them a number, uh, and that kind of thing guides a lot of medical decision making. And I think it's the kind of thing that AI is going to achieve as well. More and more our medical care is going to be run by the numbers.
Yeah.
So I hope that we can get some scientifically sound numbers in there, and that's what our team is working on.
Excellent. Yeah, this has been great, Terry. Thanks so much for spending time with me.
I've really, really enjoyed it, Jill. These are fantastic questions. Great
Thank
fun.
you.